therapy-related myeloid or cancer in general have been obviously a big problem for many years, but now that certain tumors like multiple myeloma, the survival of the patient has almost doubled in the last 10 years, it means that patients live longer. And so if the risk of these therapy-related tumors is higher because we have more patients in follow-up and more patients can experience them. So the number of patients will experience this complication is pretty high. And these complications are often life-threatening. So the worst-case scenario is when you have a patient with a complete eradication of its disease in remission after 5 years, having a leukemia and dying for it. That's what we don't want, and that's why we want to understand why this happened and how we can prevent. Now, there are studies showing that all the therapy-related myeloid tumor, not all the solid tumor, or not all the cancers that can occur after chemotherapy, but the myeloid, are always preceded by the clonal hemopiesis, which is this small clone detectable and a very low fraction in the blood. Now, the paradigm that has been held for decades is that the chemotherapy damages this clone, and this clone becomes more aggressive because of the damage of the chemotherapy. Now, using again whole genome sequencing, that is this approach that allows you to cover the entire genome and identify all the mutations, you can define with mutational signatures analysis which mutational processes are involved in this mutagenic activity or in mutagenic insult. And we know that certain drugs like platinum and Melphalan, every time you give them, each cells, normal or tumor, acquire hundreds of mutations. So we can link those mutations to an exact time point in a patient life. Now, what happened is that we observed that most of the therapy-related myeloid after platinum have the chemotherapy of platinum. So platinum introduced a lot of mutations. But for Melphalan, that is usually given for transplant, what we observe is that there is no sign in more than half of the patient. And then we wonder why this happened. Well, Melphalan, differently from platinum, is given for transplant. And transplant is a process where many patients know you collect the stem cell from the patients before the chemotherapy, and then you infuse the stem after the chemotherapy. So if you collect the pre-leukemic clone and you reinfuse after the chemotherapy, the pre-leukemic clone will not get the genomic damage. So we show in a pretty robust way that most of the therapy-related AML after Melphalan are reinfused with the transplant and not survive to the Melphalan. But that also points to the more interesting question. If the genomic damage is not present in most of these cases, but the risk is very high, it means that the genomics damage is not essential. So it's there in some cases, but it's not in all. And it means that there are probably other features, probably like immune suppression or other elements that the chemotherapy alter that might affect this. So we think this is like a bit of a paradigm shift, saying that the genomic damage is important, but is not like what the tumor or the pre-tumor clone needs to become a full tumor.